Mike Contos for Cardiosource's Biomarker Community website. Today I'm here in San Francisco at ACC's 2013 National Meeting. I have the pleasure of having Dr. Kenneth McDonald and Mark Ledwidge, who are presenting their late-breaking clinical trial, the STOP-HF trial. Can you tell us a little bit about the trial?
Certainly, prevention of heart failure in many ways is a holy grail of cardiovascular care, and present approaches are probably suboptimal. Biomarker-based risk stratification could help improve care and prevention of heart failure. And so we designed the St. Vincent Screening to Prevent Heart Failure study, the STOP-HF study, to see if natriuretic peptide-based screening and collaborative care could reduce the prevalence of heart failure and left ventricular dysfunction. And in many ways this is based on other data, including Framingham data, showing that heart failure events are predicted by natriuretic peptide, and in fact many other major cardiovascular events are also predicted by natriuretic peptide. It's a prospective, randomized, open study with blinded endpoint analysis. We screened more than 3,000 patients, of whom 1,000 did not meet the eligibility criteria, which were very broad, over the age of 40, with the presence of at least one other of the conventional cardiovascular risk factors. We randomized 1,374 patients to control and intervention. And in all patients, we assessed natriuretic peptide annually. In the control group, they received usual care from the primary care physician, and the BNP levels were blinded to both patient and primary care physician. In the intervention group, the natriuretic peptide levels were made available to the primary care physician, to the patient, and annual cardiovascular risk assessment was informed by the NP level. And in addition, the reassessment of natriuretic peptide level annually allowed us to bring patients with high levels, and we chose a level of 50 picograms per mil of BNP, into a collaborative care program, and those patients received echocardiography, specialist review by the cardiologist, and then collaborative care for the remainder of the study. The primary endpoint of the study was assessed at the end of a mean follow-up of 4.2 years, and we ensured that all patients were followed up for at least 12 months.
So that's very interesting. It's different than many of the other prior BNP-guided trials in which they took patients with heart failure and tried to treat them to bring the BNP level down. Instead, in this trial, you were looking at primary prevention in people with mildly elevated BNP levels.
Well, this is correct, and also the design is pragmatic. It was in 39 primary care practices with a single referral center.
Okay. And what were the results, Dr. McDonald?
The primary endpoint we were assessing was the development of heart failure or significant left ventricular dysfunction. And we defined significant left ventricular dysfunction as left ventricular ejection fraction less than 50%, or the presence of significant asymptomatic diastolic dysfunction defined as an EE prime level greater than 15. We also are reporting here at this meeting on the main secondary endpoint, which is cardiovascular admission for major adverse cardiovascular events. What we found in this trial is that the intervention, which Mark has described, produced a 40% reduction in the primary endpoint over the 4.2-year follow-up. This impact was seen across the three components of the primary endpoint. There was a halving of the incidence rate of heart failure and also a reduction in systolic dysfunction as well as diastolic dysfunction. The impact was seen most obviously in the group that had a BNP over 50, which is what we would anticipate, where there was a reduction in the event rate from about 18% to about 9% over the follow-up period. In addition to the impact that we had on the primary endpoint, there was also a significant impact on major adverse cardiovascular events requiring hospitalization, expressed both in time to first event as well as in the total number of events. So in terms of the merit of the intervention, it affected both the primary endpoint and the major secondary adverse event.
The results are very interesting and provocative. What do you think the next step should be?
There are two particular areas we're going to be looking at. The first, as Mark was pointing out, the admission criteria to this study were somewhat general. It may be by making them somewhat more specific that we'll get a more cost-effective and clinically meaningful result. The other issue we'd like to look at is the biomarker cutoff level. We've taken a BNP level of 50 based on some previous pilot work from our centre. But we know that maybe a lower BNP also may be as effective, or may show risk factors, or may give us a better impact on the risk on the outcome. So we'd like to look at the lower BNP level and also potentially combine it with other biomarkers that might portend risk.
Thank you both for joining us here for CardioSource here in sunny San Francisco.